Ready? Good evening, everyone. Good evening, everyone.
Good
How was
evening.
your day?
Good evening.
Good evening. Trust our day went well.
Good evening.
Okay, so welcome to today's class. So I want us to reach out to if you have a friend or a colleague that is meant to be on this call and is not yet on the call. Please invite them because our speaker is already on ground. I'll be starting by 8:30 on dot to enable us and finish on time. So today we'll continue with ICF discussion. So the topic says we'll compare the WHO ICF and other forms of classification. Yes, and our speaker today is Dr. Andrew. So, sir, I don't know if you're ready for us. What? Hello, Dr. Andrew. Are you ready for us, sir?
Hi. No, so a part of the strategy.
Please, can we kindly mute our mics? Can we kindly mute our mics so we're able to hear our guest when he starts? Thank you.
Hello. Huh, bro? I greet you, my brother. No verse, I never call you since morning.
Good evening, everyone.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir.
How are you?
Fine, sir. Good evening and welcome.
Thank you. I don't know. My laptop has been booting for over 15 minutes now. So I'm not able to connect to Zoom. So I've been restarting over and over again. So Tumishe will share the slide so that I would be able to present through the shared slide. So I've told her to share. So please, you have to tolerate it that way. I still used it to make presentation yesterday. And now is not joining again, so I don't know what's going on. So I will have to present from my phone. So Tumishi, please, you can share the slide so that we start early. Again, I would like the presentation is a continuation of what was done last week by Dr. Aike.
Please, can we kindly mute our mics? Please mute your mic. Check if your mic is mute or muted. Just mute it, please.
Thank you, Vicky. So Tumishe would share my slide. We'll hold on for Tumishe to share the slide. Once she does that, we will start. Now, like I said, tonight's lecture excuse me, is actually a continuation of last week's lecture by Dr. Ohaike. Dr. Ohaike has covered the whole frame of what the ICF is all about. This evening's lecture is more of overview of what Dr. Heike has presented. Also, to see how far or how much of it we understood and how we can so this tonight's lecture is actually a continuation of Dr. Heike's lecture. So I will try as much as I can to make it as interactive as possible. So while the lecture is ongoing, if you have any question for this particular one, because looking at the title, ICF discussion continues. So it's not a typical presentation where I would want to finish my presentation and before people can ask questions. It's actually, if you feel I should stop or you have a question, just raise up your hand. I will pause and answer and respond to that without necessarily having to finish the whole of the presentation. I will just implore all of us to please mute so that when you are called, when you raise your hand and you are called, then I will pause and listen to that question and respond. So like I said, this is discussion continues about from what was discussed last week, which is a full presentation. I must also say that the CF is not something to be covered in an hour. So Dr. Heike actually did her best to compress it in such a way that she can cover as much as possible. This is the reason we are now having discussion continues on it. So please mute yourself. I don't know. I mean, so one have to deliberately unmute on Zoom to be able, because you have to click on it to unmute. You don't have to unmute yourself if you, I mean, if you know you have other discussions you want to partake in. Anyway, so this is your boy here, Uthman Olaiwola Anjorin. I'm your boy, so just take it kindly and don't ask me questions that would throw me off balance. Next slide, Sumishi. The next slide. Okay. So we will dig a bit deeper inside the World Health Organization, the ICF, and rehabilitation. Within this whole frame, we are looking at intervention planning using the ICF, how to plan treatment. Please go back to the previous slide. I've not finished that. Okay. So it's also relayed, when you use the ICF, you need to relate the significance of impairment in one function to the overall development of the child or overall functioning as it applies to the adult. So what that meant basically is that you don't look at body part in isolation from the being, because that impairment is not more important than the person. So you cannot, in rehabilitation, focus so much on the impairment above the person. So you must relate it within the overall frame of the person. Also, we will try to look at how we can develop an integrative management plan that address the child problem or the adult problem, sorry, at the level. Again, I think I made a mistake there. I will edit it, or maybe everybody should edit it. We are not looking from the level of impairment, it's actually from functioning, please. I was so busy when I just wrote this slide out yesterday, so, and I've not opened it since morning. I will have detected the mistake. Please, everyone, try and correct it. You don't focus on the impairment from functioning. The impairment is not more important than how that individual functions, not the impairment. Because if we over focus on the impairment, then you will lose. Please mute yourself. So please, that's an error. I traveled, I wrote this yesterday night, and while I was writing, I was also in another meeting of, in another clinical training meeting, which I was listening and I was writing on my laptop at the same time. So if you see any error, please pardon me. I would explain it immediately now because I know the slides have been shared. So please edit it. It does not have to address the child. It's either the child or the adult problem. But we are looking at the problem from functioning, not impairment. Please, that's a mistake. Next slide. Okay. So we just briefly WHO defined rehabilitation as a set of interventions designed to optimize functioning, reduce disability in individuals with health conditions. Sorry, please go back to the slide. I've not finished that. Okay. Again, we can define rehabilitation in another perspective as a multifaceted affair involving physical, psychological, and social factors. Please, the previous slide. Please hold on. Let me say the next slide before you change the slide. Another important thing. Sanis Abibu, please, can you mute yourself? I don't know why people do this. We can also look at rehabilitation that it aims to maximize persons' ability to live, work, and learn. So when the goal is to maximize a person's ability to live, work, and learn, we cannot focus on the impairment. It's about the functioning. To live, you need to function. To work, you need to function. To learn, you need to function, not the impairment. So the aim is to maximize functioning and minimize the handicap, because the impairment, yes, can lead to a handicap situation, but you need to minimize the handicap and maximize functioning despite the problem. Next slide, please. Okay. Now, we need a tool inside rehabilitation or for all our work. Basically, we use a lot of tools, which we call outcome measures. But again, here is the challenge sometimes we do have, because we were taught outcome measures, but the outcome measures focus on the tools themselves, while measuring health outcomes focuses on the overall paradigm of the society, the person, the individual, and seek to analyze it to find a solution to societal needs and how society impacts the person. So there is a huge difference between outcome measures, which is talking about the tools you use to measure, and measuring health outcomes that looks at overall dynamics of the health system, the person exploring the system, the society that makes use of the system. So what are the outcomes of this health and how do they engage with it? So measuring health outcomes can look at issues more broader. Again, measuring health outcomes helps us to look at. Please, can you mute yourself? Can you mute yourself? I think the administrator should mute everyone except the facilitator. So we need to classify, because the ICF itself is a broad classification. We need to classify, especially in the field we are practicing. So why do we need to classify? Identification of groups of disorders and prognosis. Cerebral palsy is a group of disorder. Autism is a spectrum, is a group of disorders. And there are a range of mental health disorders. So when we classify, it helps us to know what we are doing and also the kind of outcome measures we can use. So classification also provides guidance for handling, intervention, and integration. When we classify, let me use cerebral palsy as an example. We can have an attitoid, we can have an atasic, we can have hemiplegic, we can have diplegic, we can have hypotonia. If I said I'm managing cerebral palsy without any classification word, it's broad. I'm talking about an umbrella that has so many conditions under it. But if I'm saying, or if I said I'm managing a diplegic CP, I have put a classification on it, which can guide handling, my plan of intervention, and how I will plan integration. So classification helps us to plan our handling, intervention, and integration. Classification also helps our practice to get better and to be able to develop service for conditions that we are seeing. Again, let me quickly say something about service development. We do make a lot of mistakes in our practice, which has been entrenched in the past. So you can go to any department, they can say they have a speech therapist service, or we have P&O service in our hospital. So also they will say they have physiotherapy service in the hospital. But physiotherapy is not a service. P&O is not a service. They are professions. Speech therapy is not a service. They are professions. Right? Those are workforce. We have used these terminologies in the past, but we need to start learning under rehabilitation to use it appropriately. For instance, speech therapy audiology might have about maybe 7 services under their profession that they do render. Not every hospital render all the 7 services, but they said they have speech and language and audiology service. Whereas the audiologists, or the speech therapists inside that hospital knew, out of about 7 things we can do in our practice, we can only do 1. But the management captures is that we have speech and language and audiology service. By categorizing it as a service, we are also undermining ourselves. If you say we have physiotherapy service, I have a private hospital. If I say I have physiotherapy service, I don't manage incontinence. It's a physiotherapy service. So I don't manage patients with mental cognitive disorder. It's a physiotherapy service, which I don't do, but I said I have physiotherapy service. So it connotes that I'm doing everything Not every hospital have all the range of specialties that physiotherapists do render. In the same way, not every P&O department in any hospital have all the services that P&O should render or be able to render. For instance, a department of P&O might not be able to do artificial limb, so they don't have that service. Or they can do the fitting, but they don't fabricate it. Maybe they don't have the ability to fabricate artificial upper limb or below knee or above knee limbs, prosthesis, but it's captured that we have P&O service. When you capture you have P&O service, what you are simply saying that you have all these services, whereas you don't have all these services. So also many hospitals don't have a physiotherapy service. So you have a workforce. That is not the service. Every department should be able to list out what service they have. If you go to any hospital, there's no hospital that will say we have medical doctor service. They will list the kind of things they do inside that hospital, the service they have. Yes, some will also list physiotherapy as a service because that is what we call ourselves as well. But you might not be able to do everything. So when we classify, we know what we treat, what we don't do. We'll be able to say we have sold service or we don't have this particular service. When we classify, we will be able to collate specific needs of groups of patients and be able to have realistic goal for them. But we have to classify what we are dealing with. That's important. Next slide. Please stop me at any time. Just raise your hand. So, the importance of classification in childhood disorders. For childhood disorders specifically, classification is only useful if it considers the severity and serves as guide for intervention planning and meaningful goal. And we need to be able to do that because when we put it in such a way that it helps us to know where we started from and guides us to know where we are going, we will be able to document progress effectively. Classification, when it comes to children, even in many cases in adults, should be dynamic. That is, we move away from classifications that tend to focus on the impairment. And if you must use a classification that focus on the impairment, then you must combine with another classification that focus on the movement, because that is what you want, not the impairment. So when you use dynamic classification, you focus on functioning, mobility, and participatory activities. In a dynamic, functional, and goal-oriented, the ICF, which is the main tool for rehabilitation, focuses on this. Either for adults or children, the ICF is dynamic. So when we talk about functioning, it is the consideration for involvement of different body parts, the pattern of tone distribution and movement. But all dynamic classification is not meant to replace universal classification. So what is universal classification? The ICF. Next slide. Next slide. Next slide. Next slide. Next slide, please. Okay, thank you. I was muted earlier, so please, next slide. Next slide. Okay. So the ICF and other classifications. Like I said, there are several classifications we use in our clinics, which is dependent on the specialties. But we must also understand that most classifications are intervention tools. Some classifications are diagnostic. Many classifications in children are also age-specific. You are not allowing me to explain the slide before you change it. you are not allowing me to explain my slides before you change it. So I don't even know how you go on with it.
There's
You are not
the
allowing me
network.
to change my slide, to talk about the slides before you change it.
If the networks, I'm actually not.
Okay. Now let me ask generally. Does everyone understand up to this stage? Because I think about 3 or 4 slides have been skipped now. Should we just go on from here? Next slide. I don't know what I can do again. Okay. So maybe when question time comes, since you all have it, can go over it. So the WHO ICF 3 levels. Dr. Heike break this aspect deeper than this. So what I'm doing here is to give a broad perspective in a way that can help people to help therapists to understand it and be able to apply it. So if you look at the level 1, level 1 on the ICF is basically talking about the impairment. And under level 1, you look at medication, surgery, and all other forms of treatment to alleviate the impairment at that time. And whatever we do at level 1, our main goal is prevent further activity limitations. So most of the things we do at level 1, casting, splinting, muscle stretch, they are all correction of impairments. At level 2, we are focusing more on the activities. And once we are focusing on activity limitation, our main goal of all the therapy we are doing is preventative rehabilitation. Sorry, again, I was muted. I didn't do that. Somebody said in the question that I should go back to the previous slides. I'm not operating my laptop. I don't know what happens. It crashed. I don't know what happened. So it's difficult for me to do that, to go back to the previous slides. I'm sorry. But if you have it in your system, any aspect that you want me to go back to, please, you can ask the question. So at level 2, we are doing preventative rehabilitation, including personal assistance, assistive aids for the patient, rehab therapy to make sure this patient is not totally reliant on support. So we focus on his own personal health. At this point, we are focusing more that the quality of life of a patient undergoing rehab is their ability to self-maintain and self-care. So we focus also on giving them assistive devices, including prevention of further participation restriction. So at level 3, we are working on participation restriction. This might include providing aids and support for them to be able to do all the activities of daily living that required help. Again, it might require environmental change, accommodation modification, educational support for them to be able to participate or do those things that matters to them. At level 3, we assess their needs and their challenges in the community and how they can access services that benefit them, or what are the priority services they need to access to maintain, sustain themselves. At level 3, we plan all that for them. What does that mean? When we work with a patient, with a client at level 3, we not only do therapy for them, we plan, we help them look at their challenges and help them, give them a program, a plan that will enable them to be able to do all the things that matters to them, including highlighting services that matters that they need to explore regularly to sustain themselves and functioning. The key thing we all need to observe here is that when we work at level 1, we are preparing for level 2. When we work at level 2, we are also preparing them for level 3. Here's the thing. There is no evidence in practice that because you manage an impairment, it leads to level 2 without you managing level 2 problem. And there's no evidence in practice that shows or indicate or suggests that because you manage a patient at level 2, it leads them to level 3. It is important for me to say this if we are going to work on rehabilitation, because a lot of us don't do this. And because we don't explore this, sometimes we read up articles, researches that seems to suggest while managing at level 1, producing report of success in level 3 with no clear guide of what have they done at level 3 that produces the result. For instance, I'm managing spasticity, and I use measures in management of spasticity, and I give a report of improvement in participation restrictions. without ever indicating that I train the patient on those activities that can restrict them from participating. I hope I'm clear. I manage spasticity to reduce spasticity. For the patient to be able to participate, for example, in self-care, he needs to go to toilet. He needs to bath himself. He needs to wash up himself. He needs to wash his mouth in the morning. However, I manage spasticity and I report improvement in participation. But spasticity is not participation. So we see a lot of this in many articles, and I've seen plenty of them, and I keep shaking my head that these people, it's because we are not into rehabilitation. That's why we can fabricate this. Let me put it more clearer. A patient had an RTI and suffers limb injury. So the surgeon amputates the limb. What the surgeon have done is to work at level 1, surgery. Every form of surgery is about management of impairment. Because the surgeon do amputation of the limb does not necessarily lead to improvement in the patient's activity if it's not done. The patient now needs to manage the stump, needs to be able to control the hip, whether it's below knee or above knee amputation. Then, working for level 2, we look at, okay, does he need the prosthesis? Okay, we give him a prosthesis, we start training on prosthesis use, right? However, the fact that he's using these prosthesis does not mean he's able to use it everywhere. We have to look at his own environment also, right? On how does he fit in? How does he participate? How does he move around his home? We are looking at his basic activities. So despite we gave him a prosthesis, it doesn't mean that he has improved his activity. We must manage his activity by actually assessing every factors that can hinder his ability to use the artificial limb we gave him effectively. We must evaluate those factors. If we evaluate those factors, that is the point we are working at level 2. Giving the prosthesis, training him on how to use the prosthesis, correction of tightness, either in the hip or in the knee, that is not the activity. You are working on the impairment. That you work on the impairment have not led to activity improvement. You have to assess what are the challenges that will restrain him from being able to engage in activity properly without limitation, without hindrance. Now, that you work at level 2. So what are we doing at level 3? Again, here it is. You gave a patient artificial limb, but this patient is so conscious psychologically that he doesn't like going to church on Sunday because of the way he's now working. That's a psychological problem now. He feels so conscious of himself that he doesn't go to parties anymore. He doesn't go to social engagement anymore because he's using artificial limb. That's psychological, right? So, what can he do? As he started engaging in social life again, that is now participation restriction. If you don't assess this same patient, were you able to go to church? Were you able to go to mosque? Okay, you go to Jumat regularly before this accident. Do you go now? And the patient said, no, I can't go. I mean, gave some excuses. You now manage either psychologically, mentally, cognitively, and look at where the Jumat is and what are the challenges in my face going to the Jumat and address those problems specifically for him That is when you manage at level 3. If you gave a patient artificial limb in the hospital and you send him home, what you have done basically is that you have skipped level 2 and you have skipped level 3. You are not rehabilitating. This is where most of us are. I hope I'm clear, right? So, next slide. I don't think this is the next slide. This is previous slide. This is the previous slide. Next slide to this. Right. This is the next slide. So, impairment, correction of management of constraint or damaged structure. This might require surgery, splinting, castings, or behavioral therapy. The goals are to optimize potential for improved functions, prevent reduction of further activities. That is what we do at level 1, which we are focusing on the impairment. Always remember, surgery, medication is just a correction of impairment. A successful surgery doesn't necessarily lead to improvement in activity. That is the role of the surgeon. Operation successful. The surgeon can do laminectomy in a spinal cord injured patient. Operation is successful. He has corrected the broken spine. Operation is successful, but the broken spine is an impairment. Successful surgery doesn't necessarily mean that the patient will be able to walk or the patient will be able to control or will not have bilateral incontinence or single incontinence. To the surgeon, the patient is alive. I have done successful surgery in correcting the impairment. It does not necessarily lead to activity. Improvement in activity doesn't necessarily lead to participation. Because when we are looking at spinal cord injury participation, then you start looking at sexual function. You start looking at the patient's ability to meet with her husband or with his wife and all that. Right? This is the reason. So there is no evidence that you work on the impairment. It leads to automatic improvement in activity results. Or working on activities automatically produce results on participation restriction without dealing with it. This is what rehabilitation is all about. You work from level 1 to level 3. When you work the whole range, that's the only time you have successfully rehabilitated. You don't get stuck in impairment and say you have done therapy, you are doing rehabilitation. You are not rehabilitating. Next slide. Yeah, activity limitations. The goal when we are working at this level is improve functions capability, prevent further participation reduction, early education, coping strategy, environmental modifications, adaptive tools, mobility tools, planning integration into community. What are the challenges? At this level, we start addressing the preparation for participation restriction. Next slide. I think I'm
Give
going
me
to
a
stop.
minute, sir. I would share the screen back. The network is actually giving me problems.
No problem. I think I will stop by 9:30 and just focus on questions and answers. The network hasn't been friendly where the hosts are based, so we are not able to flow properly. But the slides have been shared earlier, so anyone who has question by 9:30 I will stop so that I'll give room for question and answer. Just go to the next slide, which is outcome measures. Right. So, outcome measures. No, next slide. I've explained the whole, yeah, right. So, now, someone last week asked questions about use of outcome measures when we are working using the ICF. And just to re-emphasize what I said, there's no need to develop any form of outcome measure for the ICF because the ICF is a universal classification. Every outcome measure that is out there, that is available, that we use, irrespective of our professions, work within these three levels. The ICF is developed by the whole world so that if I classify a patient in Nigeria based on my report using the ICF, if he goes to Japan, it's the same thing. You go to US, it's the same thing. And every outcome measure will work either at the impairment level, activity level, or participation level. Every outcome measure works on these levels. None is outside that. But because we don't work at the three levels, that is where, like I said last week, we have challenge that we will not know where does the outcome measure we are using, where does it fit? And this is probably one of the reasons that when we use outcome measures, because we are not working inside ICF, we give reports totally outside the range of that outcome measure, which I've given examples of how we use an outcome measure and give a report at another level without using the outcome measure on that level or showing that we have done something to address at that level. For instance, I used the issue of artificial limb, which we all know. Some surgeons even want to do therapy. They will do amputation in their hospital, go and get artificial limb and give to the patient. And yet the patient will still not be able to work because they are not working at levels. So when you work at impairment level, I just give an instance, then we are working at muscle strengthening. Any measure you are using to measure muscle strength, muscle power, tightness, you are working on the impairment, not the activity. It's an impairment measure. Spasticity measure is an impairment measure. So when you are working at activity limitation, for instance, I'm using pediatrics now, right? So you are looking at GMF, you are looking at GMFCS, you are looking at PEDI, you are looking at ASK. That is activity limitations questionnaire. And when you are working at participation restriction, you use the other measures, all these measures, the CAPE, the POTC, the ALH, they are quality of life measures. Quality of life measures, how the patient is able to cope within his environment or her environment, be able to do those things that matters to them previously or right now at this moment. to be as independent as possible. So those measures are totally defined for different levels. Next slide. So in rehabilitation, we do assessment, but we must also understand that assessment is intervention. Assessment is intervention, and you have to get that clear that once you say you are doing assessment in rehabilitation, that assessment you are doing is part of your intervention. That also meant if you assess a patient in rehabilitation and the patient needs a service that you cannot render, the fact that you have identified that problem, you don't tell the patient, we cannot, I don't know what to do about it. Now, when you refer to the appropriate place for the patient to get the right service, you have intervened. The only time you did not intervene is if you have not assessed. What does that mean? Okay, a patient is referred to me and I did my assessment. Now, I'm not a speech and language therapist. And I realized that this patient will benefit from speech and language therapist. So, based on my assessment, I gave the patient referral to the speech and language therapist. I will document in folder in my intervention on that aspect. Patient also have speech problem. My intervention referred to the speech therapist. I have intervened. I don't neglect any aspect. Patient have this so ABCD problem, which I don't do, but I'm not going to say or neglect it in my assessment. On this aspect, I have referred to the ENT. I have referred to the orthopedic surgeon. I have referred to so place. That is my intervention because I have guided the place, this patient to do the right thing. So your assessment is your intervention. There is nothing like it's not my area, so I don't guide the patient to get the right service. You must provide solution. Now, practically, when we are doing assessment, we move the hand, we move the patient, we check joint stability, we check neck pain, back pain, hip pain. If we are going to treat the patient, these are the things we are also going to do. We are going to mobilize the hip, we are going to mobilize the neck. All this we have done during our assessment is our intervention. So if you are not skilled in mobilizing the neck, you probably should not be able to do a comprehensive assessment. Somebody who is an expert in the area should do the assessment and tell you what to do. That is where we now have competency level 1, 2, 3, 4. 1 needs guidance of somebody who will do the assessment and now prescribe what to do at competency level 1 and 2. So it doesn't mean that you can do everything. That's why your assessment is intervention. Next slide. Okay. We should, as much as we can, look at every client we have and cover all these domains as much as possible. Cover all these domains as much as possible. That does not mean that the patient has a problem in all the domains, but going through the domains allow you to make sure nothing is left untouched on the patient and the right services are recommended for the patient. Next slide. So, during rehabilitation, we do not treat the organ, rather restoration of functions. So I said, please help me correct the first slide. The disease is not more important than the person. The person comes before his or her disease. We focus on improving quality of life. Again, there is no short-term goal or long-term goal on quality of life. We cannot plan a patient's management in rehabilitation and set quality of life for a long-time goal. It's like somebody telling you, oh, you have to wait until you are 90 years old before you live good quality of life. So what happens that I cannot live quality of life at the age of 30? The patient might not go back to what they used to be before the injury, but at every stage of their recovery, you must make sure you look at their quality of life, whether they are fully recovered or not. Even the patient in ICU, you must look at their quality of life, how they are being sustained, the kind of care they receive. Is it adequate? Is it inadequate? So there is no time that you leave quality of life for a short-term goal or a long-term goal. You must make sure quality of life is sustained at every stage of recovery, at every time, including our own personal life. Please enjoy yourself. Don't wait until you are a billionaire before you live good quality of life. Everywhere you find yourself, give yourself good quality of life. Give yourself a treat. Love yourself. You can't love somebody else if you cannot love yourself. Otherwise, if you don't love yourself, you'll be a bitter person. You become odd people, because I suffered, so everybody must suffer. Because I live a miserable life, then I must make everybody around me life miserable. Because you don't love yourself. People that do that don't live good quality of life. They don't love themselves. You can only love others when you learn how to love yourself. Please, give yourself good quality of life. Don't postpone that until some other time. And if you meet people who is not allowing you to live good quality of life, you might need to excuse yourself from them. It means they are toxic. So our intervention must work within those rehabilitation domains and make sure we cover each and every one of them. Always remember, any disease condition that medication can totally cure cannot be under rehabilitation. The only thing that can come under rehabilitation is the impairment of any organ. Next slide. I think I should stop now. This is 9:36. Please, I will take questions now. I will take questions now. Questions?
Thank you so much, sir, for the class. Please kindly raise up your hand if you have a question. We have one hand up already. Kindly raise up your number. You'll be unmuted to ask your question. Thank you.
Good evening, sir. Good evening, moderator. Good evening, everyone.
Leman, how are you?
Fine, sir.
Yes, sir.
Thank you very much, sir. My first question is with respect to these 93 selected interventions in that table. Please, where can we get those interventions? Then number two, sir. Hello, sir.
Please come again. Where can we
see the interventions? This table, yes, this table, there are some interventions listed with respect to cerebral palsy and the other table also. So please, where can we get the interventions?
Okay.
That's number one. Number two, with respect to coping strategy in activity limitation, yes, level of intervention. So, sir, considering WC in cerebral palsy children,
Okay.
can we allow them to continue doing WC? Because the baby or the child the mothers report to us that the child can sit for more than 4 hours using WC. But if you force the child to sit properly, like long sitting or high sitting, the child cannot sit for 30 minutes.
Right.
So can this be considered as a coping strategy, that WC? Then I think the last is with respect to impairment level. Please, how possible is it to achieve, to correct activity limitation without properly correcting impairment level? I don't know if my question is.
That's a wonderful question. Now,
thank you very much, sir.
All the domains that you see listed.
Yes, sir.
If you take cerebral palsy, that list you see, we use cerebral palsy as a broad problem because that is one of the most complicated problems in health with different dimensions to their problem. In fact, when we were working on the WHO document, these packages of interventions in rehabilitation, every other condition was completed, either adults or children and others, was completed over 8 months. We are still battling with cerebral palsy to agree all over the world. Musculoskeletal problems, stroke, spinal cord, we don't have any problem with those ones. Cerebral palsy took us a long time to show you the challenge. Now, the list that you see there are lists of things you must look at and assess in that child to know where is the problem and now be able to manage them. Here again, the challenge we have is that most of our training from undergraduate level, we were trained to just look at movement, mobility. We are not trained to look at cognition, mental functions. We are not trained to do all the things that is listed. That way, we are limited in our practice. This is the reason also we are very afraid of technicians because we are very limited. The range of the things we are supposed to do is so huge, but we are so restricted to just some aspect. Now, it's not possible for you have mentioned a child with diplegia now who use WCT. No matter what you do, for instance, if you did not assess mental cognition of this child, even if he doesn't have bad mobility problem, if he doesn't have cognition, he will still not improve properly. If he's retarded, he will still not improve. So it means that mental cognition is foremost to predict the outcome of management of cerebral palsy. That's why it's on number one list. Even in stroke, a patient who suffers stroke and lose memory, lose retention of information will not recover like that one that is sound mentally, cognitively. That's why it's at number one. That's why it's at number one. But we don't assess it. We just want to move. Now, every single list you see there, there are also breakdown steps under it. For instance, mobility. For instance, mobility. I'm not with my laptop. I will have opened the original document for you to see that under mobility management, we have 11 steps to take. 11 steps to take under mobility alone. Now, The package of intervention was developed for at least 17 disabling conditions, Parkinson, stroke, and all that. In some workshop, I have opened for Parkinson, I've opened for spinal cord injury, and okay, we want to manage Parkinson. And I opened the list, which they gave us a guide of what to assess, how to assess, and what to treat. So they have in under assessment, we have for Parkinson patient, we have about 28 assessments. And we have about 25 interventions. And I asked the therapists, among all these 28 assessments that you must do for Parkinson patients, before you can say, yes, I have completely rehabilitated this Parkinson patient, how many did you do? So out of about 28, all the therapists only do about 6 assessments. This shows that our training is grossly inadequate for us to move up inside rehabilitation. And like I said, this is the reason why all of us, we are always afraid of technicians, because we are working at basic level. We are not working at the level of experts. When you work at the level of expert, those are the things you are supposed to do. I would advise, finally, that this workshop that gave a guide on how to do all those things was done last year, at least in the 6 geopolitical zones. Many people did not attend. Some attend in some centers, many people did not attend. It will be repeated. Please attend once it's repeated, wherever it is repeated, where they talk about domains and the application of PIR. This is what the workshop is all about. Now, you talk about W-sitting.
Yes.
W-sitting for children is actually, if you call it coping strategy, well, it is coping strategy, but it's a coping strategy that you know that is not a good coping strategy because it's not good. It's a trick balance system,
Of
right?
course.
So,
Yes.
because you know it's a coping strategy, that is why you come in as an expert, that a patient have developed a mechanism to cope. But I know I will not ask myself as an expert, how long? What is the consequence of this coping strategy? And how long can this patient use it before he loses it together? I mean, totally. For instance, a child who uses W-sitting will not be able to sit inside classroom for education because he can't balance. So it means even if this child is intelligent, he will not be able to cope educationally. It means that coping strategy I must eliminate because it will hinder his ultimate progress. Again, a child who mastered W-sitting, by the age of 4 going to 6, they will have developed so much adductor hip tightness. Then Achilles heel tightness, to the point that by the age of 10, they will have stopped walking because they can't move the limb anymore. The knee will have knocked, the ankle will have twisted, and the hip will have locked. So as they get bigger, taller, older, their movement, they start declining.
Definitely.
Even the floor will become more difficult. Then they have no choice except to be crawling on the floor. So you can see that this coping strategy, though it's serving a purpose now, as an expert, you start thinking, how long can this work before this child loses everything that you have worked for years? By the age of 10, stop using it. Your goal in management of this child is to make this child as independent as possible. But what you are seeing as coping strategy, by the age of 10, everything you have worked for will have become null and void. Then you must start working to change. You must start working to change because that is not a good coping strategy. Do I make sense,
Okay.
sir?
Thank you, sir. I'm getting you, sir.
What other question did you ask?
With respect to activity limitation, can it be corrected or can
Right.
it be rehabilitated without
Right. Correcting
appropriate?
impairment.
Yeah,
Yeah.
exactly.
Again,
Exactly, sir.
again, here it is.
Yes, sir.
I will use the same child, that diplegic child.
Yes.
Clinically, for you to manage a diplegic child successfully, you must start very early. Diplegic children don't develop type 1, type 2 muscles in their limbs. The pattern of adaptation, because it is spinal cord driven through central pattern generators, diplegic children quickly develop tightness of the muscles. The muscles naturally are slow type 2 fibers for diplegic children. Because I know diplegia triggers an early identification of the muscle fibers into type 2 fibers, slow acting fibers, I know I must, from very early, make sure the muscles are pliable, even though their movement might be slow, but I minimize contractures. I minimize adaptations that they might develop. However, I know because of their pattern of movement, also, their gait is driven by the Achilles muscles. That is why they tend to come on their toes.
Okay.
Their gait is driven. I would, from very early, know where those adaptations will come from and start managing it early. Because once they develop it, it's difficult to release because that is what they are using to drive their movement. And let me say this before I forget. Once you have a child that have developed with diplegia, that have developed those tightness, if you go for tendon release of the Achilles, they stop walking and they may never recover walking again. Okay. Careful. Because once you take out what they use, then you eliminate their gait totally. So how do you now work on the impairment and still promote activity limitations? You are working on impairment, not for the impairment as a goal, but rather to minimize problem that will reduce their activity. Like I've just explained, I start management early, knowing where the problems will come from. And I start working on those impairments with the intention to make sure that their activity will be sustained. I'm not stretching muscles for the sake of stretch. For instance, if I have to put that diplegic child into cast, while the cast is on, I must train gait continuously.
Okay.
I wouldn't put a child in cast to stretch it while the child is at rest. Remember, the pattern is established early. Immediately you remove the cast, all these children always go back to the same pattern. The tightness will reestablish again because you keep them not using the pattern you wanted. So if I must put a cast, I must have a plan on how to change the pattern, the gait pattern,
Okay.
to what I wanted them to be, or what I wanted to be, right? Or what I want them to use. So while the cast is on, I'll start training the normal pattern that I wanted intensely. So I will never put a cast that will make them totally bedridden just to lie down. Once you do that, you are working on the impairment, not the activity, not even preparing for the activity.
Okay.
So work on the impairment with the aim of improving the activity, not for impairment for the sake of impairment. Again, I'm dealing with another child or a patient who have muscle weakness. So I engage in muscle strengthening. So I do my shakaku every time. Load sandbag, 2 kilogram weight, 1 kilogram weight, and all that. That weakness is a correction of an impairment.
Of course.
Right? Okay. So how do I now work on muscle weakness and preparation for the activity? Again, the brain does not recognize muscles, it recognizes movement.
Of course.
So I spend hours of therapy working on muscle strengthening without working on the context in which those muscles will practice or will move. And then I'm working on the impairment. I'm not working on the activity because I must put those muscles to work within the context in which I wanted them to use it. That is the only time muscle strengthening makes sense.
Okay.
The brain does not recognize muscles, it recognizes movement. So I must use those muscles in the context in which I want the brain to recognize it, to move as normal as possible. So I wouldn't do muscle strengthening for the sake of strengthening, which is what we are doing in our clinic. Put a patient under body blaster, under multi-gyms, thinking is going to lead into improvement in activity. I've seen a lot of things like that, but it's a lie. It can't work. Okay, my brother, let's look at it in another way. A boxer who wants to throw punches, use his punches to hit on bag, on punching bag, to train his muscles. He's not going into the gym to be lifting weights, 30 kilogram weight, 40 kilogram weight, because he wants to be able to throw punches. Because he can build those muscles, it doesn't mean the power will be there to punch.
Okay.
I hope you get me clear.
I'm getting you, sir.
So a boxer who wants to be able to punch goes to the gym and use punching bag because he must train the muscles within the context he wants to use it.
Okay.
Ronaldo works in the gym, kicking ball that is stationary, to kick over and over and over again to train his muscles to be able to kick ball. He's not going into the gym to just strengthen and build muscle, thigh muscles. Now, if you take a weightlifter into the gym, into the boxing ring, his muscles might be big. And you put him beside a boxer. Before you throw one punch, the boxer will not. The muscle is big, but it's big enough to be able to snatch weight. It's not big to be able to throw punches. Because he didn't train the muscles in that context.
Okay.
So muscles have to be trained in the context in which you want to use them for the activity you want to use it for. Not in a static way. That's why I said you must do it in a dynamic way. Again, most of the things we do in our clinic, we do it in a static way and claim we achieve results in a dynamic way. Those who are working with adults, a lot, make all this mistake without understanding that this patient was able to improve because he already knows what he's doing before he had the stroke. Not because you put him in a static way is the reason why you get the result. Do it for a child. Train a child in one static way, you will not get results in another way. Garbage in, garbage out, because that child with cerebral palsy have not practiced it before. So he's not going to use it within the context in which you achieve. So if you achieve it in adult, it's because that adult is already 60 years old before he had the stroke. So you ask him to be pulling on multi-gym. You now say you improve his gait. He knows how to walk before and he's improving himself. It's not because you put weight on his leg that make him improve his gait pattern. No, it won't transfer to that. You must train muscles within the context you want to use them. That is the activity. Now, neuroplasticity occurs based on task, intensity, repetition. Muscle strengthening does not lead to neuroplasticity. Muscle strengthening does not lead to function skill carryover. We are just working on muscle strength. There's no way you can work on activity limitations when you are static. You must put it within the context you want it to be used. I hope I'm able to explain. Okay.
Thank you, sir. Thank you very much, sir.
You're welcome, my brother. You're welcome, my dear. So next question.
Okay, so we have a question chat box. It says, "Sir, please can you kindly explain this current transition from physical impression to physical diagnosis?" Yeah, so in bracket, this ICF model impairment of function, activity limitations, and participation restrictions.
Can I see this slide?
So did you get my question?
Thank you. I was talking, I was unmuted. I was muted again, that's why. So please, the question again. Let me see if I can see the question again. I was
Okay,
muted,
it's in
that's
the
why.
chat box.
Mm.
So it said, can you kindly explain this current transition from physical impression to physical diagnosis? That's the
Okay.
model impairment of function, activity limitations, and participation restrictions.
Physical impression to physical
Yes,
diagnosis.
yes,
Okay.
sir.
This ICF model of impairment, function, activity, limitations, and
That's it, sir.
participation.
Yes, sir.
Again, right. Your impression, which I think, I always have, personally, I always have, let me say, a kind of an opinion about writing my impression as a diagnosis. Because I know in many training, they put an impression as diagnosis. My impression does not necessarily have to be what the patient is experiencing. But my impression is about what I perceive when I see the patient. Then I need to dig deeper to now make proper diagnosis of that, not an impression. Your diagnosis should not be my own impression of that. It should be clear. Again, let me try to explain that. My impression of a patient, for example, a patient who have Cushing syndrome, my impression is that this patient is always tilted to one particular side. Maybe he's not balanced. It's an impression because I see his body sway to one side every time. And every time I try to correct this patient, he restricts, he doesn't want to be corrected that way because he feels he's falling. However, in my assessment, to make the proper diagnosis, I realize his bending is about more of his impression of himself in space. It has nothing to do with weakness of his body. But it's possible in my impression to say one half of the body is weak. That's an impression. It's just an assumption. It might not be the reality. So, like I said, you know, a lot of us comes from different perspectives. We shouldn't be, let me be clear, we shouldn't be that this is my perspective, that's my perspective. It shouldn't be in clinical practice, because if we work on impression, it's difficult for us to develop clinical practice guidelines. It will be difficult for us to have uniformity because we are working based on my impression, your impression, Aisha's impression of a case. Diagnosis should be clear, not based on impression, because it is only when we have clear diagnosis that we can pull resources together. We can pull resources together to form a practice guideline, to form a standard guideline when we are working based on individual impression. But like I said, I know in many instances, you will see our students are trained that clinical, your impression as your diagnosis. No, stroke is stroke. It shouldn't be my impression. My impression of that stroke might be some of the things that I see about this patient, how he interacts. Okay, my impression can be, yes, this patient is cognitively aware of his environment and cooperates with instructions given in the clinic, is my impression. My impression is not stroke. If he's diagnosed as stroke, hemiplegia, whatever, is stroke, it's not an impression, it's a clear diagnosis. But my impression might be so many other things that I see. Yeah, it's a stroke patient, moves in so particular pattern and ways and all that. And I mean, well, it doesn't seem to be cognitively aware of his environment and doesn't follow instructions, which gives an impression that he might have amnesia or something. That is an impression. That is not my diagnosis of the patient. So impression should not be diagnosis. Otherwise, it's a total mislead. I hope I'm able to explain. So physical diagnosis should not. Now, if you are not going to place your physical diagnosis on the ICF, excuse me, if you are not going to place your physical diagnosis, under ICF, now, I have to use a clear case again. Let's come back. Let's repeat. We have a patient that we have our diagnosis as a physical diagnosis, let's say, I have double incontinence post spinal injury, right? Okay. That diagnosis of double incontinence under function, activity limitation, participation restriction, what am I looking at? I will now place, I want to manage incontinence. I'll place that incontinence under this function, activity limitation, participation restriction. I hope I'm clear. So the bladder, the bowel, what is its function? Then what's the activity of the bowel? I'll place it. Is this patient able to toilet? Does he suffer constipation regularly? And what are the factors that increases his constipation? Now I'm looking at activity of the bladder and the bowel, right? Then I will look at participation restrictions. Was he able to do the front and back by himself, or will need a catheter, or will need a fecal bag? participation. Now, despite this, is he or she able to engage in other activities without help or support? Now I'm looking at participation restriction. So if you make a diagnosis of stroke, what the stroke itself is not the functional activity limitations, but rather what that stroke patient presented. Initially, maybe he has full paralysis of one side of the body. That is function. And I'm working to improve his activity. So I work for the muscle strength to improve. I work for him to be able to gain control of his posture in sitting and standing. Now I'm working on activity limitations. When I now gain his activity, he can now walk around. I move into participation restrictions. How far can he go to toilet by himself? What can he do by himself in terms of his activities of daily living, in terms of his participation in the community? Can he drive if he used to drive? Can he drive himself again? What can he do and what can I do to help him at that specific training that he needs to do for him to be able to drive again? Then I will engage in that. Are there any activities he needs to be able to learn or specific muscles I can train, strengthen for him to be able to engage in some activities he does? Then I will work specifically for that. So I will have to replace the patient on function, activity limitations, participation restriction. At this point, you are not working for gross. You are working for specific things that will improve the quality of life of the patient. I hope, again, I'm able to explain that.
Okay, sir. I think you did a good job at that. Please, we have one hand that is raised, Abdurrahim Aishatu. So I think maybe after our question, we'll call it a day because already after 10.
Go ahead, Aisha.
Okay, good evening, sir.
Good
Thank
evening,
you for
sweetie. How are you?
fine, thank you, sir. So my question is about intervention for skincare. So previously, I had not really think about any treatments that we can actually use in this domain, but recently we have like a lot of patients that had burns injury, be it pediatric case or adult case. So it got me thinking that are there any evidence-based intervention that we can use specifically for skincare intervention, or anything that we can focus on that is just probably going to be for skincare? Thank you.
Right,
That's my question.
right. Now, I've forgotten the name. There are creams, not Demazine. Demazine is a skincare product which you must use wherever there are burns issues and all that. Then prevention of contractures is key in skincare. We combine with use of Demazine. But there is a particular medication also that is used in management of keloid, which is a major problem post-burns, formation of keloids. But right now, I've forgotten the name of these that is important for you to apply. They use a lot of pressure garments. The pressure garment allows smooth healing without hindrance to therapy of skins and prevent formation of keloids. But we don't use pressure garments here, but they are veritable tool to minimize formation of keloids and prevent contractures and deformities post severe burns. So those are the things we do basically. It's more of that prevention. Then, applying those creams to spot that we know have tendency to develop keloids to make sure they do not develop. they do not develop keloids, including use of pressure garments. But we don't have pressure garments in Nigeria. I've not come across one. But yes, I saw a lot of it back abroad, but I've not come across one in Nigeria. Hello. I hope I'm able to answer your question.
Yes, sir. Yes, sir. I
Okay,
totally get
thank
that.
you. Thank you then.
Yes, sir.
So over to you, Victoria.
Okay, sir. Thank you so much, sir, for the class. I know we'll continue with this class later because some of the things we are not exhausted. I can tell that you still have lots of things to share with us, but because of time, we have to call
Right.
it. Yes, sir.
Okay.
I have to call it a night. So
Thank you.
thanks so much, sir. Please can we
Thank
appreciate
you.
Dr. Andrew? Thank
Thank
you
you.
so much, sir.
I can see a lot of my boss here. Minkaila. I can see him here. I can see Aisha here. Camille, Ayomikun. In fact, I've got a lot of Tolu Alashe, Akinkunle. So I hope you are enjoying Abeokuta. Thank you, everyone. Good night.
Thank you, sir.
Thank
Good
you.
night, sir.
Thank you,
Good
sir.
night, sir.
Good
Thank you,
night,
sir.
sir.
Good night.
All right. Good night, everyone. Have a good night rest.
Thank you so much, sir.
Good night.
Thank you, sir.
Thank you. No
Good night,
quiz.
everyone. Good night. God bless you all.
Good night.
Good night, everyone.
Enjoy the rest of your night.
Good night. Is there no quiz this night?
Respond.